Hello, salam alaikum. Is my voice clear?
Yes, clear.
Okay, welcome everyone. Thank you for joining. So we will continue for the next day. Today we are going to discuss the approach for station 5 and the approach for station 2. Okay, then we will apply the approach in some cases by practicing them, actively practicing them, and we will try to discuss some of the related cases also. Okay, so regarding station 5, okay, station 5, as you know, the total time for the station from outside is 20 minutes. 20 minutes. Okay, you have got 2 cases within this 20 minutes. Okay, each case 10 minutes in total, 8 minutes with the patient. Okay, and 2 minutes for the examiner's question. Okay, so before this 20 minutes, we have got 5 minutes of preparation, 5 minutes to prepare yourself before the exam. They will give you a very nice white paper and pen to start preparing for your cases, for both of them, by the way. Okay, so use this 5 minutes wisely in order to prepare for your station. Okay, so in total, you have got only 2.5 minutes for each station, for each case, I mean, for each encounter. Okay, so you will be moving from another station. Okay, you will move to the rest area. Okay, and after you finish your preparation, you will be moving to the next station. Okay, so this will take in total, in general, you'll be allowed only around 3 minutes. Okay, so try to prepare only for each case a maximum of 2 minutes. Each case should take maximally 2 minutes. Okay, so if I ask you a question, which case you are going to prepare first? Is it case 1 or 2? Any idea? We'll be preparing for case 2 first. Case 2 first, okay? Because when you enter the station, if you try to prepare for the first case and then you prepare for the second case, okay? When you enter the case, you will face case 1 and you were preparing for case 2 actually, okay? So this might create some confusion. So try to prepare for case 2 first, then move to case 1, okay? So when you enter the station, you will face case 1, which you already was preparing for. Okay, this will make you more focused. It will be easy for you to approach the case. Okay, when you finish case 1, you will take the paper out of your bucket. Okay, you will go over your second case quickly, just looking at the differential diagnosis. Okay, and then proceed with the second case. Okay, so the timing, which is 5 minutes for preparation. Okay, and 20 minutes for approaching the station itself, both cases. Okay, so how to prepare for your case from outside? Okay, so you will have less time compared for preparation compared to with session 4. Okay, because here you are having only 5 minutes. Okay, to prepare for 2 cases instead of 1 case in session 4. Okay, so you will not be able to write much in your paper. And even inside the exam, okay, you will be examining the patient and taking history at the same time. So it's almost impossible for you to have a look in your paper. Okay, so all you will write in your paper, okay, you will just write your role, okay, and you will write the patient name and age. Okay, then in the middle, in this square, you are going to write the positive data mentioned from outside. Write the positive data mentioned from outside. Okay, especially sometimes they will give you the vital chart from outside. They will give you, for instance, high blood pressure or high temperature. Okay, this is going to be very important. If you do not write it, okay, during the presentation of your finding, you might forget that this patient from outside, they have mentioned to you that his blood pressure is high. So in this area, try to write the important positive data provided from outside. Okay, even if they provided data regarding the history, for instance, duration of symptoms, whatever, just try to write it here. Okay. And as you can see, I did not write full sentences. Okay. As usual, try to adapt some abbreviations, especially for you. Okay. From my practice, I know that D in GMC means doctor in general medical clinic. Okay. D in GIT, doctor in gastroenterology clinic. Of course, I'm not going to say gastroenterology to my patient because this is jargon. Doctor in intestine and gut clinic or whatever, but try to avoid medical terms, okay? And write in abbreviations to save your time, okay? Write in abbreviations, okay? Even if you can see, I wrote only John. Even I did not mention, I did not write Mr. John. I just wrote John 29. Even I did not mention 29 year. Anyway, we are medical specialists or physicians. Okay, so we are not dealing with pediatric patients. Definitely, the age is in years. Okay, so this is how to save your time and prepare quickly. Okay, after this area, okay, in which you wrote the positive data, the positive important data. Okay, below this immediately you will write your differential diagnosis. Okay, just write 1 or 2, maximum 3 to 4 differentials. Okay, because most of the time from outside the complaint might be misleading. Sometimes from outside the complaint will be different from what the patient will tell you inside. Okay, so never think deeply about the differential diagnosis from outside. If they provided enough data, okay, and you feel that you will be able to put some differential, you can write it here in these 2 lines. Okay, then after that, just write PDFs and Abbas driving. PDFs and Abbas driving. Okay, the P is for the past medical history. Okay, when I enter my session, when I finish asking about the past medical history, I will put a tick here. Okay, drug history, family history, social history. I know that I have finished all the history points. This is very important. Okay, but it is not necessarily that you will ask about anything in details, because in session 5, it is only targeted history. Okay, you are not required to take full history like in session 2. Okay, and it's completely acceptable also to do this examination, okay, and the history at the same time. While doing my examination, I can ask the patient about this PDFs. Okay, then Abbas driving is a mnemonic actually. Okay, when I finish taking the history, when I finish my examination, I will be speaking about the plan, what needs to be next for the patient. Okay, immediately I will have a look. I will sit down, I will have a look in my paper. Okay, and I will start explaining the diagnosis. Okay, and then when I come to the management plan, I will look to my Abbas driving. Okay, the A is for admission. Does this patient need admission or not? Okay, so this patient is dehydrated, he needs fluid correction. So Mr. John, I'm going to admit you to hospital, okay, because we need to give you some fluids to correct your water loss. Okay, then the P is for pain control. Pain control. Okay, if the patient has got joint pain, headache, abdominal pain, anything, you have to help him. Okay, so I will give you painkillers to help with the pain, Mr. John. Okay, then the A, if the patient is taking much alcohol, if the patient is taking much alcohol, okay, and I did not give him advice when he mentioned this, I will remind myself here at this stage, okay, that Mr. John, please, I advise you to moderate your alcohol intake. Okay, the S is for smoking. Again, give advice against smoking. Okay, if it is not done earlier. Okay, then the D is for driving. D is for driving. If the patient has got a medical condition which prevents him from driving, I will tell him, please, Mr. John, I would like to ask you to stop driving and notify the DVLA, because this medical condition might, if you drive with this medical condition, this might put you and the public at risk. Okay, so from outside, this is all what I am going to write. station name and age, my role, okay, some of the important positive data mentioned from outside, then differential diagnosis if they provided sufficient data for me to think about differentials. Okay, then I write PDFs at bus driving. That's it. And I will enter the station. Okay, so before we discuss the approach, okay, we would like to know how they are going to score you inside the exam. How are they going to score you inside the exam? Okay, so in station 5, the total score is actually 28. The total score in station 5 is 28. Okay, because all 7 skills are tested in this station. All 7 skills are tested in this station. Okay, yesterday, when we discussed station 4, we came to know that only 4 skills are tested, and for each skill, 4 marks. Okay, so the total score for station 4 is 16. In station 5, because you are going to take history and you are going to examine your patient and you are going to detect physical signs. Okay, and according to this, you are going to mention differential diagnosis. Okay, you are going to communicate this to your patient and explain the management plan. Okay, so this is the station. This is the only station actually in PACES which all 7 skills are going to be tested. In station 5, okay, all 7 skills are going to be tested. Okay, so are you able to see my screen now?
Yes.
Okay, so starting from the first skill tested in session 5. Okay, clinical communication skills. Clinical communication skills, by the way, it is not only tested in station 4. It's tested in station 4, station 2, okay, and of course also station 5. Okay, so how are they going to score you satisfactory? Okay, this is the assessment sheet the examiner is going to use to score you in session 5. Okay, so in order to score satisfactory within the clinical communication skills within session 5, I mean, in order to get the full mark in session 5 in communication skills, okay, you have to elicit relevant history, okay, explain information to the patient in focused, fluent, and professional manner. Okay, your history should be targeted, not like in session 2. Okay, should be targeted history. Okay, and then after that, you have to explain to your patient in a clear way, okay, what is his diagnosis. Okay, sometimes you will not have a diagnosis. Even after history and examination, you will not have a diagnosis. Okay, just like your daily practice. Sometimes you will need to do some investigation and CT. Sometimes you need to admit the patient for further evaluation. Okay, it is not necessarily that you should tell him a diagnosis. Okay, you can even explain differential. Okay, or you can even agree a management plan together. Okay, to be honest, till now I did not reach to the bottom of your diagnosis. What we need to do now, this is very important, because as soon as you say this, the examiner will listen carefully, because here he is evaluating not only 1 skill, 2 skills. The first skill is the way that you are communicating to your patient. Are you communicating clearly in a professional way? Okay, this is going to determine how many scores, how he will score you in clinical communication skill. And the second thing, okay, does your plan of management seems reasonable or not, sensible or not? Okay, because this will affect your clinical judgment. Okay, so relevant history, and explain your to the patient, okay, whether you have got a diagnosis, or in case you do not have a diagnosis, you can explain differential. Okay, and then move to explain the plan of management. Okay, so this is how they score you in communication skills. So how they are going to score you unsatisfactory, okay, if you omitted important areas of the history. Okay, if you were unpracticed, unprofessional, poor explanation to the patient. I did not explain well to the patient. Okay, let us assume that the patient has got let us say joint pain, knee pain. Okay, and his concern was DVT. Okay, and he asked you, doctor, do I have clot in my leg? This was his concern. You said no, you have got inflammation in your knee joint. Okay, despite that, you told him the diagnosis, you did not answer his concern. His concern whether he has got clot or not. So you have to be clear and straightforward. No, you do not have clot. Okay, what you have is inflammation in your knee joint. Okay, and check understanding. Okay, you have to give clear explanation, clear and straightforward. Okay, and never omit important points of the history in session 5. Okay, your history has to be relevant, okay, targeted, and at the same time you should not omit any important information. So the second skill, which is physical examination skill, okay, this of course is going to be scored according to whether you did all relevant physical examinations or not, okay, and whether you did it in a proper way or not. Okay, again, this is for the total score is 4. Then clinical judgment, as we mentioned, your plan should be sensible. Okay, your plan should be sensible, should make sense. Okay, correct, appropriate, practiced, and professional. Okay, how they are going to score you in clinical judgment. Okay, your plan should make sense. Okay, if you do not have a diagnosis, at least tell the patient what are you going to do. Okay, then skill F, which is managing patient concern. Okay, whenever the patient mentioned any concern, we mentioned the way to deal with it. Appreciate, give information, okay, and then check understanding. Appreciate, give information, and then check understanding. In this way, you will get the full mark in managing patient concern. Okay, and most importantly, never overlook a patient concern. This is particularly important in session 4. Okay, at the start of the consultation, sometimes the patient will throw like 1 or 2 concerns while he's when you ask about his background, about his medical condition. What do you know about your medical condition? He will start giving you some information. In between, it's a usual practice for surrogates to give 1 or 2 concerns. Okay, if you moved on to fill the gaps in his knowledge and then explain further, okay, and you did not answer his concerns, this is called overlook patient concern. You did overlook a patient concern, which is very dangerous. Okay, and as we discussed earlier, okay, managing patient concern skill is very dangerous because the pass window is very narrow, as you can see here. Okay, in skill F, okay, managing patient concern, the total score is 16. Okay, and the pass is 10. So you have got only 6 marks. Okay, and more than this, you will fail not only the session, you will fail the entire exam. You're going to fail the entire exam. Okay, so take care in clinical communication. Okay, then differential, identifying physical signs. This is skill B, identifying physical signs. Okay, you did examination in a proper technique. Okay, and you did all aspects of his examination which is required. This is skill A. Okay, skill B is which findings you were able to detect. Were you able to detect all physical signs or not? If, for instance, the case has got 4 positive findings, each one is going to be scored 1. Okay, if you mention 2, they are going to give you 2 out of 4. Got the point? So this is skill B. Okay, and by the way, some people might tell you that if you mention a positive finding which is not there, this will cause you to fail the exam, which is totally incorrect, because inventing a sign, as you can see here in this paper, okay, will affect only identifying physical sign skill, identifying physical sign skill. Okay, so if you mention a physical sign which is not there, still you can pass the exam because it will affect only one skill, okay? Identifying physical sign. And this skill, particularly this skill, has got a good pass window, okay? So you can mention a positive finding, finding which is not present, I mean, and still pass the exam, okay? And I previously, one of the candidates, he shared with me his experience, okay? It was mentioned clearly. It was mentioned clearly that he mentioned findings which is not there. He mentioned findings which is not there. This was in session 5. Okay, still he got 25 out of 28. 25 out of 28, and he passed the exam with high score. Okay, so saying that mentioning a positive, mentioning finding which is not there, I mean inventing sign, will cause you to fail the entire exam. This is not accurate at all. Okay, if your performance in general was okay, this is not going to cause you to fail the exam. Okay, then we have got also skill D, which is a differential diagnosis. Of course, you have to put a sensible list of differential, and the most likely diagnosis should be on top of your differential diagnosis, on top of your differential diagnosis. And here there is a very important point I would like to mention. Okay, whenever you mention any differential, never forget to mention relevant investigation to rule it in or out, and relevant management plan for it. Okay, let us assume that I have got a patient with back pain. I mentioned that the differential diagnosis is most likely brucellosis. Okay, and then I put tuberculosis and trauma as differential. Okay, when the examiner asks me, okay, how are you going to investigate your patient? If I mention investigation for the most likely diagnosis, which is brucellosis only, and omitted investigation and management for tuberculosis, definitely, and believe me, they are going to comment on your feedback, and they are going to deduct some score out of your clinical judgment. Okay, because it does not make sense, okay, to suspect tuberculosis and do nothing about it. Okay, so whenever you mention any differential, okay, when you speak about the investigation and management plan, you have to take it in mind. You have to take it on board. I would like to do blood culture. I would like to do CSF. Okay, I would like to do the immune system, whatever. Mention something for tuberculosis. You have to. Okay, because I have seen many feedbacks. Okay, examiners were commenting on this. I will share with you some of the feedbacks in the group after the session. Okay, but the examiner did write in a very clear and straightforward way that the candidate omitted investigation for the differential diagnosis. Okay, so take care. Then you have got the last skill, which is maintaining patient welfare. Maintaining patient welfare. And as we have discussed, this is the last skill you'd like to lose marks on it. Why? Because it is very easy to get the full mark, 32, and very easy to fail this skill. And when you fail this skill, you will not fail the station, you will fail the entire exam. Okay, you have got only 4 marks to lose. Okay, 5 marks, you will not lose only the station, you will lose the entire exam. Okay, let us assume that in one station, you caused physical discomfort to a patient. The patient said, while examining for carpal tunnel syndrome, okay? And when you moved to the next station, okay, you find a female lady and you ask her about period, okay, or illicit drugs without taking permission. And this has caused her emotional discomfort. Here you did lose 4 marks out of your skill, okay? Only one other mistake and you will fail the exam. Even if you score 150, you are going to fail the exam, because you can either fail with the total score or you can fail with skill, as we mentioned yesterday. Okay, so this is how they are going to score you. Hope this is clear. Okay, this is how they are going to score you in station 5. Okay, is it clear so far?
Yes, clear.
Yes, clear.
Okay. Okay, so now we know how they are going to score you, and we know the time schedule for the station and for the preparation from outside. Okay, we know how to prepare for the case. Now we are going to discuss how are you going to approach the case. How are you going to approach the case of session 5? Okay, is the picture clear in the screen now?
Yes.
Okay, so this is my personal approach. Okay, I have used this for many years. Okay, and I found that it's very useful and very helpful. Okay, you can try to modify as you want to make it fit your brain. Okay, everyone, the way you think is different from one to another. Okay, but I think this is going to be very helpful because I am not the only one who tried this. Okay, many colleagues, I told them this approach and they found it very useful. Okay, so when I enter the station, okay, in my paper I have wrote the patient name and age, okay, and my role and anything. Okay, so when I enter the station, hello there, my name is Dr. Tahir, one of the medical doctors in the clinic today. This is fixed. No good morning, no good evening to avoid confusion. Okay, one of the doctors in the clinic today. No need even to mention heart clinic or gut clinic, nothing. My name is Dr. Tahir, one of the medical doctors in the clinic today. Okay, immediately I will have a look in my paper. Is it Mr. John? Yes, doctor. No need to ask about his age. Keep it simple. Okay, there is no time for this. Okay, Mr. John, we are here. Okay, I am here to ask you some questions regarding your health, and I may need to examine you at the same time. I am here to ask you a few questions regarding your health, and I may need to examine you at the same time. Okay, don't mention I would like to take history from you. This is not a proper expression for this for taking the history. Okay, history taken, okay, is for doctors. This is understandable for doctors. For patient, I would like to ask you questions regarding your health. I would like to ask you questions regarding your health. And by the way, in session 5, as we mentioned, it is completely acceptable to ask questions and do examination at the same time. But you have to take permission from the patient, because if you talk to him while doing the examination, he might feel annoyed. So you have to take his permission first. Okay? Then immediately I will start with an opening question. I will start with open question. Okay, and please try to keep your open question wide open. Try to keep your open question wide open. What do you mean? Okay, some people might mention, it came to my knowledge that you are complaining of joint pain. Tell me more about it, please. Here you are closing your open question. Okay, and the surrogate or the patient is going to speak only about his joint pain. Okay, but if you tell him, what can you tell me, please, what brought you into clinic today? Can you tell me, please, what brought you into clinic today? Here he might volunteer very valuable information at the start of the station. Like for example, he might tell you, I was diagnosed 10 years ago with rheumatoid arthritis. Recently, within the last 3 months, I have got pain in my hands and so on. Okay, so here he's providing you very vital information, which is very useful to reach the diagnosis from the start. So try always to keep your open question wide open. Okay, after this open question, add another open question. Tell me more about it. Here again, the surrogate has to provide you with more important information. He will give you more information. Okay, so not only open question, try to even make it double open question. Okay, because I'm telling this because I have seen many candidates starting their history by asking the patient, I received a letter from your GP mentioning that you have got joint pain. Tell me more about it. This is not the correct way. May I know what brought you into clinic today? Sometimes even the complaint mentioned outside will not be the main concern of the patient inside. Sometimes the complaint inside might be different. They will tell you one complaint, inside the patient has, for instance, 3 complaints. They cannot write everything from outside. So it's very important to keep it wide open. Okay, so as soon as he mentioned the complaint, okay, I will analyze that complaint. I will analyze that complaint. Okay, but in session 5, the analysis is not like session 2. Okay, just try to ask few questions which will give you the diagnosis. Okay, and by the way, most of session 5 cases, okay, are spot diagnosis. Okay, for example, when you enter the station, you will see that the patient is obviously cushingoid, and from outside they gave you back pain and high blood pressure and high random blood sugar. So just by looking into the patient face, I know this patient has got back pain, most likely related to osteoporosis as complication of Cushing syndrome. Sometimes I will tell you that the patient has got abnormal movement or tremor. When you enter inside, obviously the patient has got Parkinson. Sometimes they will tell you the patient is complaining of weight gain and tiredness. When you enter inside, the patient is obviously acromegalic. Okay, so here I will not waste my time asking unnecessary questions to analyze the main complaint. As soon as I see the patient, okay, I get an idea about what could be the diagnosis, and then I will ask only few questions to confirm my suspicion only, okay? And then I will move immediately to systemic, to analyze the system involved, okay? So as you can see here, I wrote CO. This stands for complaining of. This is the main complaint, okay? This line after the main complaint, okay, should remind me about asking, should remind me to ask about the duration. Okay, so Mr. John, you mentioned that you have been complaining of back pain. For how long has it been going over? For how long has it been going over? For how long? Ask about the duration, okay? He will mention, doctor, it has been going over for the last 3 months. Here, immediately, I will use this to my advantage, okay? So, Mr. John, you mentioned it has been going over for the last 3 months. What about your health in the past? Before this 3 months, have you been diagnosed with any medical condition before? Do you see any doctor or any nurse about anything at all? I will try to squeeze the surrogate about his past medical history, okay? Because usually this is the most important part in session 5. Usually, this is the most important part in session 5. Let us assume that a patient is complaining of skin tightness around his finger. Okay, from outside, I put 2 differentials, systemic sclerosis and diabetic cheroarthropathy. When I enter inside, when I ask him this way, okay, if he tell me, doctor, I was diagnosed with systemic sclerosis for the last 10 years, خلاص, this is the diagnosis. Okay, but if he mentioned, doctor, I have been diagnosed with diabetes for 20 years. Here, the suspicion of diabetic cheroarthropathy is raising above systemic sclerosis. So this is very important. Okay, open question, tell me more. Okay, for how long? Okay, as soon as he mentioned the duration, ask prior to this duration. Okay, so you mentioned it has been going over for the last 3 months. Before this 3 months, what about your health in the past? Have you been diagnosed with any medical condition at all? Okay, sometimes, especially if the complaint is abdominal pain or headache. Abdominal pain or headache. Here you have to ask about previous episodes. Previous episode. There might be no diagnosis, no previous diagnosis, okay? But when you ask the patient any previous episodes of headache, he will tell you, yes, doctor. Any diagnosis, have you been investigated? No, doctor. I just visit my GP and he will give me some medicine. Which medicine? Somatriptan. Halas, this headache is migraine. This headache is most likely migraine. Full stop. Only because I asked about previous episode. I have got abdominal pain, doctor. For how long has it been going over? For the last 3 days. Previously, have you been, did you get any episode of abdominal pain? Any previous episodes of abdominal pain? Yes, doctor, I do get this tummy pain frequently. It's a tummy pain, by the way, not abdominal pain, because abdomen is gargle. Yes, doctor, I get tummy pain frequently. Every now and then I get tummy pain. So previously, did you see any doctor about this tummy pain? Have they done any investigation to you? Did you receive any medicine for this pain? He will tell you either, yes, doctor, previously I was admitted and diagnosed with familial Mediterranean fever. But most likely, he is not going to tell you the diagnosis. He might tell you that, yes, doctor, I was admitted previously and received medicine called colchicine. Here, my suspicion is confirmed. This is FMF, familial Mediterranean fever. Yes, doctor, previously I have been suffering the same tummy pain several times. In one occasion, I was admitted and they took away the appendix. They did surgery for me. Okay, but still I do get the same pain. خلاص, confirmed. Okay, because I know that FMF present with several episodes of tummy pain associated with fever, and sometimes, okay, by mistake, they will be diagnosed as appendicitis and they will undergo appendicectomy. Okay, so it's very important to ask about past medical history and to ask about previous episodes. When? Immediately after duration. Okay, and you have to ask the same way, because if you do not link it to the duration, you will seem disorganized. The examiner will comment that this candidate is disorganized. I will show you some feedbacks also. The examiner has wrote very clearly that this candidate is disorganized. So being organized in the way you ask is very important, by the way. Never underestimate this. Okay, that's why I'm telling you this is how to ask. You mentioned it has been going over for the last 3 days. What about your health in the past? What about prior to these 3 days? Here I'm not disorganized. I'm linking the time frame together only. Okay, he will tell me the past medical. He will tell me if he has got previous episodes, and then I will continue analyzing the complaint, starting by onset, whatever. I will ask according to my differential diagnosis. After I finish analyzing the main complaint, okay, as you can see here, I wrote T and A plus I. T and A plus I. T is for timing questions, for how long has it been going over, any previous episodes, how did it start, okay, is it increasing during the day or night, any question related to time, I will ask. Then the A is for analysis. I will analyze this main complaint, okay, according to my differential diagnosis. And plus I, the I is for the impact, okay. If you see the examiner assessment sheet, okay, it's always written clearly, okay, within the examiner assessment sheet that you should assess the impact of the symptom. You should assess the impact of the symptom or the disease on the patient life, on the patient job. Okay, you have to assess the impact of the disease on the patient. I will show you the assessment sheet. So here within clinical communication skills, okay, are you able to see the second point? It is written clearly. Assesses impact of symptoms on patients' occupation, lifestyle, and activities of daily living. So never miss the impact, okay? Never miss assessing the impact, okay? That's why I put I with the timing analysis of the main complaint, as well as down also within the social history. Again, I am going to stress on assessing the impact. Okay, then after I analyze the main complaint and after I assess the impact of this complaint on the patient, I will move to the system involved. Okay, the patient has got joint pain. The system involved is the musculoskeletal system. The patient has got chest pain. The system involved is cardiopulmonary system. I will start by analyzing that system in details. Okay, SI stands for system involved. Okay, then I will move to the constitutional symptoms. CS means constitutional symptoms. I mean the general symptoms. Weight and appetite, fever and night sweat, skin itch, and skin rash. Okay, and as you can see, I have wrote +2. +2. What do you mean by +2? Okay, I mean whenever you go to PACES, okay, whenever you enter session 5, whenever your case is endocrine case or something which seems to be of autoimmune nature. I am dealing with Addison, I am dealing with pernicious anemia, type 1 diabetes, okay, autoimmune polyglandular syndrome type 2 is suspected, okay, I am dealing with Cushing, I am dealing with acromegaly. Here, immediately, I will add to constitutional symptoms 2 important questions. Okay, the first one is weather preference. Mr. John, are you abnormally sensitive to hot or cold weather? Yes, doctor, I'm always hot. regardless of the weather. Okay, I'm always hot, doctor. No matter how the weather is cold, I'm always hot. This is hot heat intolerance. Heat intolerance. So immediately I will go down the pathway of confirming thyrotoxicosis, the 5 H's: handshake and tremor and weight loss and loose motions and so on. Okay, doctor, I'm always cold. Regardless of how the weather is hot, I'm always cold. I always feeling cold, doctor. Immediately, any weight gain, any hard stool, any dryness of the skin. Okay, I will go down the pathway of hypothyroidism. So this question, weather preference, is to screen mainly for thyroid diseases. To screen for thyroid disease. Okay, and the second important question is dizziness on standing from sitting position. Dizziness and standing from sitting position. Why? Mainly to say to search for Addison, or if your patient is diabetic autonomic neuropathy, okay? Sometimes even to screen for dehydration, because so mainly 3 differentials. Autonomic neuropathy if your case is Addison, if your case is diabetes, sorry, okay, and the second differential is Addison disease, okay? And if your patient has got losses, diarrhea, vomiting, okay, to search for water loss, okay, or dehydration, okay? And if you find dizziness standing from sitting position positive, don't forget when checking his vital chart to request bedside sitting and standing blood pressure measurement, okay, to confirm postural hypertension. Okay, in this way, I will screen for all the autoimmune conditions. Okay, how come? Okay, so whenever you go in PACES and your case seems autoimmune in nature, you have to screen for the others. I have got autoimmune thyroid disease. I have to search for all the other autoimmune conditions. I have got Addison. I have to search for all the other autoimmune conditions. Mainly, they are 2D, which is diabetes and Addison. Diabetes and Addison, okay? And 2C, which is celiac and thyroid. Celiac and thyroid. And 2P, which is pernicious anemia and premature ovarian failure. Pernicious anemia and premature ovarian failure, okay? Premature ovarian failure is not relevant basis-wise, okay? But mainly these 5 differentials: 2D, Addison and diabetes, 2C, celiac and thyroid. I know thyroid starts with a T, but the pronunciation seems like a C, so make it easy for yourself. 2C, celiac and thyroid, and 1P, which is pernicious anemia. Okay, doctor, this is too much to screen in session 5. I have got only 6 minutes. Okay, all you need to do is to add these 2 important questions to screen for thyroid disease and Addison or diabetic autoneuropathy or whatever. Okay, just 2 questions you will add to the general symptoms. Okay, the rest will come naturally, even if you do not ask for them in particular. Okay, let us assume you are you want to search for celiac disease. Within the GI symptoms, any problem is your bowel? Yes, doctor, I have got a loose motion. Is it difficult to flush out of the toilet? Yes, doctor. Is it related to specific type of food? Yes, bread and pasta. Celiac is confirmed. So no need to add a specific question. Already you are going to screen for loose motion within the GI. Let us assume that you are going to screen, you want to screen for diabetes. This will come in the past medical history. Okay, let us assume that you would like to screen for pernicious anemia. This will come within the CNS when you ask the patient any change to sensation, any change to sensation. Okay, so in order to screen for all 6 questions, you just need to add these 2 questions to the constitutional symptoms. Okay, so after I finish analyzing my main complaint and then analyze the system involved and then analyze the constitutional symptoms, here immediately I will start my examination. Okay, analyzing the main complaint will narrow the differential. Analyzing the system involved will narrow the differential further. Analyzing the constitutional symptom will again narrow the differential further. Okay, here I would like to examine the patient to confirm my most likely diagnosis. Let us assume that the patient has got in history chest pain. From outside, a lot of differentials within chest pain: pneumonia, ischemic heart disease, heartburn, Okay, muscular, costochondritis, a lot of differentials, pulmonary embolism. This is from outside. But when I analyze the main complaint, I will find that the pain seems pleuritic in nature. Okay, it does not increase with exercise, it is not exertional, and it is not related to position. So it is not pericarditis. This is pleurisy. Here, instead of us thinking about ischemic heart disease, okay, thinking about pericarditis, I am thinking about pneumonia, other causes of pleurisy, okay, such as pulmonary embolism. Okay, so I will ask more questions within the system involved. I will the patient has got chest pain, so the system involved is the cardiopulmonary system. When analyzing the cardiopulmonary system, which is the system involved, I detected that the patient has got cough productive of greenish sputum. Here, pneumonia is going to the top. When I come to the constitutional symptoms, the patient has got fever. So here, pneumonia almost confirmed. Okay, so here, when I start my examination, I will auscultate the chest, there is crepitations, my diagnosis is confirmed. Okay, this is the way you should narrow your list of differentials in session 5. So after finishing the constitutional symptoms, okay, I will start immediately the examination. Okay, and by the way, in session 5, there is no time to think or try to remember anything. Okay, you have to keep the approach like your name. Okay, that's why I try to make mnemonic for everything. Okay, for example, for the examination, I have got a fixed mnemonic to complete the examination. I know that as soon as I finish my constitutional symptoms, okay, whether I needed to add the 2 questions or not, immediately I will start examination. How to start examination? VLS. The V is for the vital chart. I will check the vital chart immediately. The L is for local examination. What do you mean by local examination? Examination of the main complaint. The patient mentioned joint pain, have a look on his joint. The patient mentioned rash, I will have a look on his rash. Okay, the patient mentioned constipation. Despite the diagnosis hypothyroidism, but I have to request to palpate his tummy. Okay, this is what we call local examination, which is the L. And then the S is for general survey. Okay. General survey is almost fixed for all patients. You just need to modify the way you do, to modify the findings according to your case. Okay. So immediately after I finish the constitutional symptoms in the history, okay, I will start examination. Okay. And before I touch the patient, I will turn my head to the examiner. At this stage, I would like to have a look in the patient vital chart. At this stage, I would like to have a look in the patient chart. Sometimes, as we mentioned, the vital chart is written from outside. So grab your paper, have a look in the vital chart. Okay, put your paper aside and start your examination. Okay, if the question of dizziness of standing from sitting position was positive, okay, I will tell the examiner I would like to have a look in the patient vital chart and I would like to measure the blood pressure sitting and standing. I would like to measure the blood pressure sitting and standing. Okay, he will tell you no need to skip, but he will give you the full market examination. Okay, at this stage, I would like to request bedside glucose testing and urine dipstick for proteins and for sugar and protein. I would like at this stage, okay, to check for blood glucose, bedside blood glucose and urine dipstick for protein and sugar. This in case I was suspecting diabetes with complication. Okay, for instance, my case of diabetic arthropathy. At this stage, okay, I would like to check for bedside blood sugar and urine dipstick for sugar and protein, because this will tell me 2 things. It will give me idea about the control, and it will give me the idea also about if this patient has got diabetes or diabetes with complication. Okay, if the urine dipstick is positive for protein, most likely this patient already developed diabetic nephropathy. And since he has diabetic nephropathy, I have to think about also diabetic retinopathy, diabetic neuropathy, because they come all together. Complications usually come together in diabetes. Okay, so as soon as I finish the V, I will move to the L. Okay, and this is very important, by the way, and this is the most candidate will forget to do the local examination. Okay, before they brought a patient of hypothyroidism, it was very clear picture, straightforward. Okay, from outside, the main complaint is constipation. All candidates, when entering the exam, they analyze the constipation. Okay, they found that the patient is hypothyroid. Okay, all of them mentioned the diagnosis of hypothyroidism. Okay, and even some of them screened for autoimmune polyglandular syndrome type 2, but no one requested to palpate the patient abdomen. Okay, the examiner commented in the feedback, did not request to examine the patient abdomen. Let us assume that the same patient came to you in the hospital. The first thing is to examine his tummy, right? Because maybe he has got intestinal obstruction. Hypothyroidism is not going to protect him against intestinal obstruction. So you have to examine his tummy. This is the main complaint. Okay, so here at this stage, whatever the patient complaint is, I am going to ask to examine it. Rash, joint pain, tummy pain, heart, chest pain. Okay, I will request to examine. Most likely, in case of abdomen, the examiner is going to tell you skip, but he will give you the score. Okay, he will give you the score. Then move to the S. Within the S, I would like to do general survey. Okay, immediately after I finish examining the local complaint, immediately I will grab the patient hand. Immediately after finishing the local examination, I will grab the patient hand, because this is where to start your general survey. I will start sometimes from the nails. In case of you are dealing with psoriasis, searching for pitting nails, oily spots, okay, transverse region, and so on, features of psoriasis in the nail. Okay, so you will start from the hand, sometimes even from the nails of the hand, and then you will move to the wrist. Okay, if my patient has got something which will cause weight gain, like hypothyroidism, acromegaly, even simple obesity, metabolic syndrome, polycystic ovary syndrome, okay, hypothyroidism, acromegaly, Cushing, okay, anything which caused weight gain, immediately here at this stage in the rest, I will examine for carpal tunnel syndrome. And as we mentioned earlier, okay, never tap in the patient breast, because this is painful test. This may cause physical discomfort to your patient, and this is going to affect the most dangerous skill, which is patient welfare. Okay, so any painful test, never do it. Ask for it. Okay, instead of examining for carpal tunnel syndrome, I will ask the patient, if I tap here over your wrist, will you feel any pain or electric sensation? Yes, doctor, carpal tunnel syndrome is positive. Full stop. No need to do it. No need to do it unless you would like to fail the exam. Then from the rest, I will move to the forearm. From the forearm, I will move to the arms. In the arm, at the level of the arm, usually I would want to do examination for proximal myopathy. For proximal myopathy, I can test the power in the forearm, in the arm, okay, and also ask about pain or tenderness, okay, because if there is proximal myopathy, it will be only weakness. If there is weakness and tenderness, this is not proximal myopathy. This is myositis. Myositis, because pain is a cardinal feature of inflammation. Cardinal feature of inflammation. Now it is, instead of proximal myopathy, okay, this is going to be myositis. Myositis. Okay, proximal myopathy can be associated with most of the station of the cases which usually appear in station 5. Cushing can cause proximal myopathy. Thyrotoxicosis can cause proximal myopathy. Acromegaly can cause proximal myopathy. Rheumatological conditions, all of them. Okay, so make it like fixed step of examination. Examine for proximal myopathy. Let us assume that my patient has got chronic, intermittent, inflammatory arthritis of the small joint of the hand. I am suspecting SLE. Okay, when I started my screening, I finished examination of the hand. Okay, I finished examination of the wrist and forearm, and then I came to the arm. Okay, I tested for power. There is weakness, and the patient is complaining of pain. I have got pain here, doctor. Okay, if I touch here, is it sore? Yes, doctor. Okay, here instead of SLE, my diagnosis is mixed connective tissue disease. Mixed connective tissue disease, because mixed connective tissue disease is association of many conditions together. Most likely, most commonly, okay, SMS, SMS. The first S is for SLE. The M is for minor screening. Okay, and the second S is systemic sclerosis. Okay, only two of them is sufficient to raise the suspicion of mixed connective tissue disease. Only if I detected myositis, instead of mentioning my diagnosis is systemic sclerosis or my diagnosis is SLE, I will mention my diagnosis is mixed connective tissue disease. Okay, then I will move to the face. Okay, sometimes I will start from the hair or behind the ear if I'm dealing with SLE, or and then the mouth. Let us assume that I'm dealing with acromegaly, big nose, big lips, interdental separation. Stick your tongue out to examine for microglossia. At this stage, I will ask for symptoms of OSA, obstructive sleep apnea, because microglossia is a cause for OSA. I don't want to go in more details at this stage, okay? But what I am telling you is that within your general survey, you will be moving in arch, starting from the hand to the wrist, to the forearm, to the arm, to the hair, sometimes even the hair, or sometimes the face, eyebrows, eyes, nose, mouth, neck, okay? According to your case. Sometimes you will need to examine for gynecomastia in the breast or ask for galacturia, okay, in case you are suspecting a hyperprolactinemia. By the way, hyperprolactinemia will cause galacturia, not gynecomastia, okay? So at this stage, instead of examining for gynecomastia, I will ask about galacturia, any milky discharge from the breast, and then I will request examining the tummy, for instance, and then I will move to the thigh. Within the thigh, by the way, you can detect proximal myopathy either in the arms or in the thigh. In the thigh, okay, you will ask the patient to stand without the help of his arms. Okay, if he is unable to stand up without the help of his arms because of weakness in his legs, this is called positive Gower sign. Positive Gower sign, and it is indicative of proximal myopathy. Indicative of proximal myopathy. Then I will move to the knee. Okay, usually I will be examining for osteoarthritis or inflammation in the knee. I mean arthritis. Okay, arthritis or arthralgia, and then the ankle. Depending on my case, I will modify which finding I am looking for. Let us assume that I am looking for hypothyroidism. When I reach the ankle, I will request from the examiner, at this stage, I would like to do ankle reflex, looking for delayed reflexes, pendular reflexes. Let us assume that I am dealing with psoriasis. Okay, at this stage, I would like to look for Achilles tendonitis and plantar fasciitis, if there is any tenderness. Got the point? So depending on my suspected diagnosis or my suspected differential diagnosis or my suspected associations, I will modify my examination. Okay, then immediately after I finish my VLS, keep it fixed. VLS finish, hold your umbrella. VLS finish, hold your umbrella. As you can see in the picture, I draw an umbrella here. What does this umbrella mean? This means it is the time for you to ask umbrella questions to cover the systemic review. Okay, in session 5, there is no time. Okay, you are not going to do full systemic review like any abdominal pain, any tummy pain, any heart pain, any difficulty swallowing, any loose motion, any hard motion, any yellow discoloration of the skin. No, it is not like that. Depending on your diagnosis or most likely diagnosis or differential, you are going to just screen the rest of the systems. Okay, for instance, when I come to the GI, any problem with your bowel, sometimes this is more than enough to screen the GI. Just any problem with your bowel. Okay, when I come to the cardiopulmonary, any pain in the chest or tummy, because inferior MI sometimes can present with epigastric pain. Okay, so any pain in the chest or tummy, here I'm screening for epigastric pain associated with inferior MI, but also I'm covering the abdominal pain in systemic review of the GI. Got the point? So any pain in the chest or tummy, any problem with your bowel, we are done. Any problem with your water work, any flow theory. This is the most important question you need to ask in particular session 5. Okay, you don't need to ask about amount, color, frequency, odor. No need for this. Any problem with your water work, full stop. Then only one more question: any frothy urine, because diabetes with frothy urine equals diabetic nephropathy. SLE with frothy urine equals SLE nephritis. Okay, and most station 5 cases usually can affect the kidney and result in frothy urine. So you need to add this question in particular. Okay, when I analyze the cardiopulmonary system, okay, I will find that only cough is missing to cover the lower respiratory tract. Only cough, any cough, full stop. And then I move immediately to the upper respiratory tract. This is very important, by the way. Okay, there is one. This case is actually station 2. Okay, if you analyze the respiratory system without analyzing the upper respiratory tract, you will not get the diagnosis. The diagnosis is Wegener, okay, presenting with hematuria, as I remember, okay. And then when you analyze the respiratory system, cough, chest pain, anything, nothing, restlessness, nothing, okay. Only if you analyze the upper respiratory tract, any nasal crusting, any change in the shape of your nose, any bleeding from your nose, it will be positive. So instead of bleeding, instead of hematuria, okay, your case is now Wegener granulomatosis. So never forget to assess the upper GI system. Okay, so CPS, this stands for cardiopulmonary system. GI and genitourinary, keep them together. Okay, CNS and musculoskeletal, keep them together. How to screen for CNS? Any weakness at all, any change to sensation. And I say change to sensation because this is umbrella cover. Okay, if you said loss of sensation and the patient saying no, this does not mean that he does not have neuropathy. Maybe it is early neuropathy and he has only burning sensation, tingling, pins and needles. Okay, we have got positive symptoms and we have got negative symptoms. Negative symptoms like loss of sensation. He has missing sensation. Positive symptoms, he has increased sensation, more sensation. Whether this more sensation is tingling, pins and needles, or hyperalgesia, for the instance. Okay, so if you say any change to sensation at all, this will cover everything, whether it is positive finding or negative finding. Any weakness at all. Okay, this is enough. Then move to musculoskeletal system. Any problem with the joint or muscle, full stop. Any problem with the joint or muscle. Okay, joint pain, joint swelling, muscle weakness, all of them, muscle pain is covered with this question. Any problem with the joint or muscle, the skin, any rash or rash on exposure to sun, any rash or rash on exposure to sun. Okay, because sometimes a patient with SLE might not have rash, but he has photosensitive rash. Okay, so any rash or rash on exposure to sun. And then this H is for the hematology. Hematology, any history of clots or bleeding before, any history of clots or bleeding before. You can ask only about bleeding if your patient is female, because within the female history, you have to ask about clots, okay? So as you can see here, I added this female simple, and the H is for history, okay? Plus or minus female history, depending, of course, on your patient, whether your patient is female or male. Okay, so if my patient is female, make sure that there is finding in the female history. There is finding in the female history. And for that reason, I made specific mnemonic to screen for the female history. Okay, 5 P's, 5 P's. Okay, pregnancy, pills, period, okay, abortion, a recent baby. Pregnancy, pills, period, abortion, recent baby. This is very important, okay? If the patient is hypothyroidism, okay, and she mentioned that she has recent delivery. When? 1 year ago. So most likely this is postpartum hypothyroidism. Okay. If she has panhypopituitarism, multiple hormones are deficient. Dizziness and standing from sitting position, features of hypothyroidism. Okay. So I am suspecting panhypopituitarism. Okay. I asked her, she mentioned, yes, there is recent delivery, recent baby. Here I will add another question. Was this complicated delivery or not? Did you suffer any bleeding or any hypotension, low blood pressure during that delivery? Yes, doctor. Here I will put which diagnosis, any idea?
Sheehan syndrome.
Sheehan
Sheehan
syndrome.
syndrome. Excellent. Sheehan syndrome. Okay. Abortion. If she mentioned 2 abortions, and here she has features of SLE. Here, my diagnosis is SLE association with antiphospholipid syndrome. Excellent. Okay. So female history is very important in station 5. Okay. If you find a male patient in station 5, you are lucky, because this will save you a lot of time. But if you find female, again, you are lucky, because definitely within the female history, there will be something. There will be some positive data, and you have got a very straightforward way to ask about the female history. Then after I finish my systemic review, I will put the umbrella aside and start my PDFs. PDFs as usual. Past medical history, if not cover. For instance, he mentioned diabetes, okay, and analyze diabetes earlier. Here I will ask about other past medical. Okay, drug history, family history, and social history. Social history, as you can see, صح جد. Okay, so the S is for smoking, the A is for alcohol, the H is for either housing or hobbies. Either housing or hobbies. This will depend on your case. For instance, if I am dealing with suspected asthma, here I am going to explore his housing environment. Okay, any recent painting, innovation process. Did you bring any birds or pets to your home? I will explore the environment at his house. Okay, let us assume that my case is suspected Hussam or ABKD or whatever, something which I need to stop tuberous sclerosis, for instance. Okay, and his presentation is Caesar. This is one of the cases which appeared previously. Tuberous sclerosis and presented with convulsion. Okay, here instead of housing is not relevant, but I will ask about hobbies. Doctor, I like climbing mountains. Here immediately you have to stop. I like going to the gym. This is vigorous activity. Okay, your patient Hussam, you have to stop. Okay, your patient is having ABKD. You have to give him warning about vigorous exercise and the risk of injury. Okay, so it will depend on your case, either housing or hobbies. And then the J is for the job. The J is for the job. And immediately after the job, I put another I to remind you to ask about the impact of the symptom or the impact of the diagnosis on the patient job. Okay, and then the D is for driving. If relevant, stop driving. Okay, then as you can see, I wrote SPT. SPT here in the social history, again, depending on your case, you might need to add sexual history. Okay, you might need to add psychiatric history sometimes. You might need to add travel history. Okay, let us assume that the patient has got fever, okay, or cough, or weight loss. Okay, any symptom which suggests infection, any symptom which has a smell of infection on it. Okay, here immediately I have to ask about recent travel. I have to ask about sexual history. Okay, and this is because tuberculosis and AIDS and these infectious diseases will be part of your differential diagnosis. Okay, then after I finish my history, after I finish my examination, definitely now I have got at least list of differential. At least, if not diagnosis, at least I have got list of differential. So I will explain the diagnosis, okay, in clear way, okay, using no jargons at all, okay, and then I will explain the plan of management. I will explain the plan of management. We need to admit you to hospital, okay, to give you some fluids to correct the water loss. Okay, this is for the instance if the patient has got dizziness standing from sitting position, and when I ask about the bedside sitting and standing blood pressure, the examiner told me it is positive for posterior hypotension. Here immediately, if I do not admit this patient to hospital, okay, and if I do not tell him that he needs fluid, okay, my clinical judgment skill is going to be wasted. Okay, patient has got bleeding of any type, melena, bleeding per rectum, fresh bleeding per rectum, epistaxis, bleeding under the skin, okay, any evidence of bleeding, okay, and here immediately I have to ask him about the symptoms of anemia, and I have to examine for anemia. If this was positive, okay, and I did not mention that you will need to be admitted to hospital, and you may need blood transfusion to correct your blood count. Here again, this is going to affect my clinical judgment. Okay, so by just looking at my mnemonic, I should ask myself whether this patient needs admission or not. If he needs admission, admission for what? If he does not need admission, what does he need? Maybe referral to another specialty. We will involve the joint doctor. We will involve the skin doctor, and so on. Okay. When I look to this P, oh, at the start of the consultation, the patient mentioned headache. Mr. John, I am going to give you painkillers. Okay. Alcohol and smoking, I advise you to give the advice right away. As soon as the patient mentioned, yes, doctor, I do smoke, I advise you to stop smoking because this is bad for health. Otherwise, believe me, you are going to forget. But in case you forgot, you can remind yourself with this mnemonic. The same for alcohol and driving. The same for alcohol and driving. Okay, so is this clear?
Yes, doctor.
Yes, clear.
I am not going to repeat the approach throughout the course with each case. Okay, so please, if any question regarding this approach, this is the time to ask. And I will send the recording in the group, by the way. Don't worry. You can listen to the recording again, stop and write whatever you want to write. But please, you have to master the approach, because from now on, we will be doing the case, okay? And I will score you accordingly, okay? And the discussion will be relevant to the case itself, okay? Not for the general approach, okay? Just one more thing I would like to add, how you can make sure that you are going to get a very high mark within session 5. How are you going to make sure that you might get the full mark, even the full mark in session 5? Okay, at the end of your history and examination, okay, before explaining to your patient, ask yourself, did I cover triple C and A? Triple C and A. In session 4, we have got triple C and M, right? M for the management plan. We are going to discuss the management plan, right? Here, we will make it triple C and A. Triple C and A. Confirm the diagnosis. Confirm the diagnosis. My diagnosis is myasthenia gravis. What could be the cause? What could be the trigger? In myasthenia gravis, it is autoimmune, of course, but here I need to search also for the trigger. There is recent infection. The patient took antibiotic. There is stress, and she is pregnant. These are my 4 triggers. I'm going to discuss this with the patient as well as examiner. Then the third C is complications. This patient has no restlessness, no dysphonia or dysphagia. So there is no acute severe myasthenia. There is no myasthenic crisis. Okay, so far, this patient is not in crisis. If there is any breathlessness, I'm going immediately to mention to her and to the examiner that she needs admission, possibly to the ICU, and she will need to be monitored for any breathing problem. Okay, and even she might need elective intubation and mechanical ventilation. This is for the examiner, of course, because this is going to cause emotional discomfort to your patient. If you tell her immediately that I am going to put a tube through your mouth, no, take it step by step. At this stage, we need to keep you monitored. But for the examiner, because this patient has got restlessness, I'm going to tell him my diagnosis is myasthenia gravis. Obviously triggered by pregnancy, recent infection, and stress. Complicated by possible myasthenic crisis. This patient mentioned restlessness, okay, and dysphonia. Okay, so I would like to admit this patient to hospital, possibly to the ICU, and I would like to consult the intensivist for possible intubation and mechanical ventilation. Possible intubation and mechanical ventilation. Okay, I do not want to go in details in this. Anyway, you have to remind yourself, clinical presentation, confirm the diagnosis, look for the cause or trigger, look for the complications, and the A here is for associations. Associations. Okay, this is of particular importance if you are dealing with autoimmune condition. Okay, you have to screen for all the associations, and we mentioned how to screen for them. So is that clear? Is that clear? After I after I finish my CCC and A, then I will explain to the patient using Abbas driving. Okay, I'll explain the diagnosis, okay, the possible causes or triggers, and if there is any trigger which is avoidable, I will advise him to avoid the trigger. Okay, I will mention the complication. Okay, for this, it's really important to admit you to hospital because this myasthenia gravis, this disease is starting to affect the muscles of your breathing. So it's really important to admit you to hospital now. Okay, then after I finish the diagnosis, after I explain the diagnosis, okay, then I will cover also other parts of the management plan using Abbas driving depending on my case. Okay, so this is regarding the approach for station 5. Now we are going to move for discussing the approach for station 2. Okay, so regarding station 2 or the history station, okay, so here you have got 5 skills which is evaluated here, 5 skills. Okay, because you are not examining the patient, of course there is no skill A, which is physical examination. Okay, but there is finding in the history, so there is identifying physical signs. Okay, just a minute, sorry. There is differential diagnosis, identifying physical signs for examination. But here, because there is data from the history, okay, you have to provide at least differential diagnosis. Okay, you have to provide differential diagnosis. So the skill D, which is differential diagnosis, being evaluated. Okay, of course, clinical communication. Any session in which you are going to speak to your patient, the clinical communication is evaluated using the same parameters. Okay, managing patient concern, the same. Maintaining patient welfare, the same. Okay, whenever you would like to ask about period, permission, illicit drugs, permission, here you are not going to touch the patient, so there is no chance that you will cause physical discomfort. Just be aware of emotional discomfort. Okay, don't be rude. If you do not be rude in this station, I assure you that you will get the full mark within skill G. You will get 4 marks. Okay, clinical judgment, the same. Okay, plan. Regarding your plan, it has to be sensible. Differential diagnosis, you should put relevant differential, okay, and the top, the most likely diagnosis should be on the top of your differential. Okay, communication skills, how is it evaluating here? Okay, they will watch out. Did you ask about the presenting complaint? Did you do systemic review? Did you do post-medical? Did you do family history, medical medication history? Okay, as you can see within clinical communication skills, it is written clearly how they are going to score you. The first point, you have to ask everything. Okay, influent and professional manner. The second point, you have to assess the impact. I cannot stress more on this. This is very important. Okay, you can be scored unsatisfactory if you did not ask your patient how this is affecting you. Okay, and then of course at the end of consultation you have to explain everything to the patient in clear and professional and structured manner. Okay, so we have got 5 skills, each skill 4 marks, so the total of station is total score for station 2 is 20. Total score for station 2 is 20. Okay, so how are you going to prepare for station 2? How are you going to prepare for station 2? By the way, we did not mention the timing. For station 2, it is total of 20 minutes. 20 minutes. Okay, 12 minutes, the examiner will tell you 2 minutes remaining. Here you should start answering the patient concern and tell him the diagnosis and so on. Okay, they will give you another 2 minutes. Okay, so 12 minutes for the history, 2 minutes to explain to the patient, and then time up. 14 minutes, the examiner will tell you time up. They will give you 1 minute for reflection. Okay, you should be thinking about your positive data here. Okay, and if you do not write them, you will never remember all of them. You will miss something. So I cannot stress more on this. You have to write all the positive data. Okay, during the reflection time, which is 1 minute, you will be able to have a look on the positive data. Okay, and then you will be able to put a differential diagnosis. Okay, use this time to put not only to put your differential diagnosis, but also you should think which is the most likely diagnosis, which one of them is the most likely diagnosis. Okay, and after you formulate your list of differential, you should think about investigation and management for which of them. At least you have to mention one investigation to rule each one in or out. Okay, if I mention my most likely diagnosis is this, my differential is this and this and this. Okay, but when the examiner asked me about investigation and management, I only consider the most likely diagnosis. Here immediately the examiner is going to deduct some marks out of my clinical judgment. Okay, so this station is the only station in which the same way of preparation from outside, okay, you will use it inside. Okay, the same paper. Okay, there is no difference in station 5. For the instance, we needed to write only the important positive data and differential diagnosis, and then PDF, Abbas driving. That's it. Okay, but here you can mention more details. You will be asking in more details. Okay, so I have got 5 minutes to prepare. Okay, try to train yourself to prepare in 3 minutes. Okay, so that it will be easy for you to prepare in during the exam time under stress. Okay, it will be more than sufficient for you to prepare in 3 minutes. Okay, and believe me, this is really more than quite enough. Okay, so I will write in the top right of my paper, as usual, doctor in general medical clinic. Doctor in general medical clinic, according to my role. I will write the rule in abbreviations. D in GMC, okay? I will write the patient name and age, and then CO is for the complaint, the main complaint. And this line is for the duration. Okay, as usual, open question, tell me more, duration, ask about the duration, and link this to past medical history. You told me that it has been going over for the last 3 months. What about your health in the past? Immediately, I will squeeze the surrogate about his past medical. I will ask about previous similar symptoms. Okay, then I will finish all the time question. Let's assume that I'm dealing with a patient of suspected asthma. Okay, does it get worse at specific time during the day or night? Yes, doctor. Okay, especially at the end of the night or late night or early morning, I do get more symptoms. It is preventing me from sleep, doctor. Okay, headache, especially at the morning with projectile vomiting. This is increased intracranial pressure. Headache in the morning, okay, and the patient is snoring at night and he never feels refreshed from sleep. This is headache related to OSA. So timing questions is very important. Okay, this T stands for timing questions. For how long? Any previous for how long and specific time during the day or night. And here I will give you a very simple tip. Any weakness which tend to get worse at the end of the day, this is myasthenia gravis. Any breathlessness, any dysphagia, any dysphonia, any ptosis which get worse at the end of the day, this is myasthenia gravis. In PACES wise, getting worse at the end of the day means and equals myasthenia gravis. Okay, then again I will assess the impact. The I is for the impact, as we have mentioned within session 5. Then SI is for the system involved. CS plus 2. We know this, right? Anyone to help me with this? What does CS plus 2 mean? Someone to open.
Symptoms.
Tell me, please.
Constitutional
symptoms. Okay. Which are 6. And the 2 questions we mentioned previously. Okay. So weight loss and weight is important without appetite. Yes, doctor, there is weight gain. How many kg? 10 kg. Was this intentional? Did you change your diet or the level of your exercise? No, doctor, it was not intentional. Okay. And how is your appetite? This is very important. Weight and appetite comes together. Okay. Then fever and night sweat also comes together, because this will raise suspicion of tuberculosis or lymphoma. Okay. And sometimes even HIV. Okay. And then skin itching and lumps and bumps also comes together. Skin itching and lumps and bumps comes together, because this is lymphoma, right? Lymphoma will cause cervical lymphadenopathy. Okay. And if there is B symptoms, there will be fever, weight loss, and skin itching. Okay. So weight and appetite, fever and night sweat, lumps and bumps, and skin itching. These are the 6 fixed questions. Okay. In session 5, only if I am dealing with autoimmunity or endocrine problem, if I feel that my case is autoimmunity or endocrine problem, I'm going to add the 2 questions. But in session 2, regardless of anything, I'm going to add these 2 questions. Dizziness or standing from sitting position and weather preferences. Okay. Then I will ask few questions for differential diagnosis. Sorry. So here there is a big debate. I bet that every one of you now is thinking about the question of whether I should ask about the differential diagnosis here or within the systemic review, because if I ask the differential diagnosis here, I will seem disorganized. If I ask within the systemic review, I will seem that I am hitting the differential diagnosis by chance, right or not? Is that what you are thinking about now? Because previously many people asked me about this question. Shall I ask the differential diagnosis here or within the systemic review? Because some PACES tutor, they will tell you to ask within the systemic review, because if you ask here, you will seem disorganized, and this is very dangerous. Okay, because the examiner immediately is going to comment about it. And some PACES tutor will tell you also you have to ask about the differential diagnosis at this stage, because otherwise, if you ask within the systemic review, you will seem as if you are hitting symptoms by chance. Okay, and you are professional and you are applying for a specialist post, so you have to be more targeted. You should not search for differential. You should not hit the differential by chance. No, you have to tell the examiner, okay, while taking history, the examiner should feel that you are searching for this differential. You are searching for the association. You are searching for the complication. So in order to solve this dilemma, my advice to you is as follows. At this stage, ask about the differential diagnosis, but how you should do it. You will ask only questions relevant to the differential diagnosis. Only question relevant to the differential diagnosis. For instance, I am searching for inflammatory bowel disease. Okay. At this stage, I will ask about bloody or mucoid motions, full stop. The rest of the GI, all the questions, I will keep it for the systemic review. Here, the examiner will understand that I am asking about inflammatory bowel disease as association with psoriasis, but also when I come to the GI analysis, I will ask all the questions related to the GI system. So I will seem organized. Is this clear? This is very important, by the way. Is this point clear?
Again, Dr. Hussam?
I will repeat again. When you come to the differential diagnosis, ask only questions which is going to confirm or rule out your diagnosis. The rest of the questions within that system, leave it to the place of systemic review. Let us assume that my case is, I would like to rule out inflammatory bowel disease. It's one of my differential, whether complication, whether association was or differential diagnosis. I would like to rule inflammatory bowel disease. When I reach this stage, I am going to ask only single question. Have you got any bloody or mucoid motions? Yes, doctor, I will put inflammatory bowel disease in my differential. No, doctor, I will rule it out. But I will not ask any other symptoms like tummy pain, throwing up, okay, steatorrhea, okay, yellow discoloration of the skin. The rest of questions related to the GI, I will leave it to the place of GI when I do systemic review. In this way, I will have screened to all my differential diagnosis. The examiner will know it. They will feel that I am professional. I am in the specialist level. I am searching for this specific differential. Okay, and at the same time, when you come to the systemic review, you will give them the sense that you are organized because you ask all the systems of the symptoms of the GI system within the GI analysis. Got the point?
Yes.
Okay, so as soon as I finish my differential diagnosis, okay, I will move to my systemic review, same as we mentioned in session 5. Okay, except here you will not use umbrella questions. As you can see, there is no umbrella here in front of the systemic review because this is station 2. You have plenty of time. You need and you can ask about everything. I will start from the cardiopulmonary system. I will ask anything covering both lower respiratory tract, upper respiratory tract, plus cardiovascular system. Then GI and genitourinary. I will do full analysis. Okay, any pain on the swallowing, any difficulty swallowing, any mouth ulcer, any heartburn, any tummy pain. Okay, any problem with your bowel, any loose motion, any hard motion, any bulky stool, any black tarry stool. I will ask everything. Any discoloration of the skin, yellow discoloration of the skin. Did anyone comment that you look paler than usual? Okay, and then I will move to the genitourinary. How is your water work? I will always start with open question and then ask in details. How is your water work? Any problem with your water work? How is the amount, color, any change in the color, any bloody urine? Okay, any frothy urine? Okay, I will ask all the questions of the genitourinary system. Any pain in your in the side of your back? Any pain at the lower part of your tummy? To ask for loin pain and suprapubic pain. Okay, so full analysis. CNS, the same thing. I will ask about history of loss of consciousness, history of convulsion, memory problem, everything. Okay, musculoskeletal, joint pain, swelling. Okay, skin rash, rational exposure to sun, difficulty on standing from sitting position because of the weakness. Okay, anything. Then hematology, history of clots or bleeding. If my patient is female, I will ask here about the 5 P's we mentioned. Okay, after finishing the systemic review, I will come to the past medical history, drug history, family history, and social history. The same PDF, smoking, alcohol, housing, or hobbies, depending on my case, job and the impact of the symptom or the disease on the job, driving, plus or minus psychiatric history, social history, travel history, depending on my case. But I advise you to keep it fixed. In session 2, you will have a lot of time. You can ask everything. Okay, after I finish this, do you see this R in the circle? This is very important. This R is very important. Okay, R in a circle plus question mark. R in a circle plus question mark. As soon as I finish all my social history, when I look to this symbol, I will remind myself, recap to this patient and ask him if he has got anything to add. Believe me, this is very important and very useful. Okay, you mentioned that you have got back pain which has been going over for the past 3 months. Previously, you had problem with joint pain. Okay, and you mentioned also burning, maturation, and discharge. It's actually painful to pee, okay? And there is pus discharge out of your penis, okay? And also you mentioned an episode of redness and grittiness of the eye, okay? Have you got anything else you would like to add? Anything else you'd like to add? Anything you think I might be missing? Okay, by the way, in the exam, in session 2, usually they will bring a surrogate, like in session 4. Okay, and you will be speaking to a doctor or nurse. You will be speaking to your colleague, actually. And believe me, he will want to help you. He will want to help you. Okay, as soon as I tell him this, okay, immediately he will volunteer a very important information. In my case, she was a patient of migraine. Okay, I forgot to tell her to stop oral contraceptive. Despite that, within female history, I asked her about contraceptive. She said, yes, I am using contraceptive. And her presentation was complex migraine, hemiplegic migraine. All of us know that oral contraceptive increase the risk of developing stroke and TIA in patients with migraine by 30%. And whenever you meet any patient with migraine taking oral contraceptive, you have to advise him to see the woman doctor, okay, to change the type of contraceptive, because this will put them at risk of developing stroke. And already they have got a complex migraine, which you are unsure whether this is complex migraine actually or TIA. So if you do not stop the contraceptive, this is going to affect your clinical judgment. Okay, I forgot to tell her. Under the exam stress, with poor sleep, I did not take my coffee. I forgot to tell her to stop the oral contraceptive. But when I look into my paper, okay, so you mentioned this and this and this and this. Anything you would like to add? Anything you think that I might be missing? Immediately she told me, do I need to stop the birth control pills or not? Can you imagine? A normal patient will not say this, because she was a doctor or a nurse, I don't know. She wanted to help. So this part is very important. Never underestimate the importance of this part. Okay, you have to recap the positive data and then ask your patient whether he has got anything to add. You can ask him straightforward. Anything you think I might be missing, he will give you the information. Okay, how to recap? As you can see in the top right of the paper, in the bottom, sorry, bottom right of the paper, I have made like area to write the positive data. While I am asking the main complaint, let us assume that she mentioned the duration is 2 days. I will write 2D. 2D, I know that this is 2 days. 2M, 2 months. 2Y, 2 years, and so on. I will write an abbreviation so that I can write everything. Sudden, this is the onset. What else can be sudden? The onset. Okay, severe. Okay, D with a small circle, this stands for diarrhea. V with a small circle, this stands for vomiting. Abd, and then P with a small circle, this refers to abdominal pain. Abdominal pain. Okay, G, then the same P with the small circle, this is joint pain, and so on. I will write in abbreviations. DM, hypertension. HTN, hypertension, HTN, sorry. DM, diabetes. Okay, if I write S in a circle and plus, this means that this patient is smoking and I need to give advice against smoking. Alcohol, okay, is positive and I need to give advice to moderate her alcohol. Okay, I will be writing as I am taking the history. And by the way, from the start, in the introduction, okay, my name is Dr. Tahir, one of the medical doctors in the clinic today. Is it Ms. Sarah? Yes, doctor. Ms. Sarah, I would like to ask you a few questions regarding your health. This is the first permission to take history. And you have got another permission. And as we go, I will be writing some notes. Okay, just to make sure that I will not miss anything. This is very important. Okay, so you will be speaking to her and writing notes. You will be speaking and writing notes. I will be writing some notes as we go, just to make sure that I will not miss anything. Okay, and I assure you that this will remain confidential. Okay, so I will be writing notes as soon as I finish my history. You mentioned that you have got tummy pain, which has been going over for the last 2 days. It started suddenly, it's severe, and you scored it 6 out of 10. There is also throwing up and loose motion, and you are known to have diabetes. Okay, you do smoke 10 cigarettes per day, and you drink only on social occasions. Any other information you'd like to add? Anything you think that I might be missing? Okay, if you do not write in this way in your paper the positive data, you will never be able to remember within your recap. Okay, then after I do this, I will go to ask the patient about the concern. See in a circle at this stage. Okay, as soon as I look to this symbol, I know that I should ask at this stage about the patient concern. What is your concern? Okay, usually in session 2 or 5, there will be no more than 1 or 2, maximum 2 concerns. What is wrong with me is fixed one. What is wrong with me? Okay, then sometimes there may be another concern, but most likely it's going to be one concern. What is wrong with me? Here I should start explaining the plan. Okay, of course I will discuss the possibilities. Okay, I will discuss what I am thinking about now. I have got a list of differential. Okay, imagine that you did not mention to the patient that you need to examine her. Okay, immediately this is going to affect your clinical judgment. If this patient comes to you in the hospital, you will take history, you will examine the patient, you will do investigation, and then tell him the diagnosis, right? So in the exam, the same applies. Okay, they are just simulating what will happen in real life. Okay, immediately immediately after you finish, I would like, what is wrong with me, doctor? So I would like to examine you first. I would like to examine you first. But from what you told me, I think you have 1, 2, 3. Explain the diagnosis or differential diagnosis. Okay, then go back to your Abbas driving. Ask yourself, do you need to admit this patient to hospital? Does this patient need pain control, alcohol advice, smoking advice? Do you need to stop driving or not? And others. Sometimes there's others. If the patient, you would like to stop contraceptive, for the instance. Okay, if you would like to advise the patient to avoid stress, for the instance. Okay, this is the time to discuss this. Okay, then time up. Immediately, again, I will go to this magical box. I will review the positive data. I will formulate a list of differential. Okay, I will think which one of them should be on top. Okay, which one should be in the bottom and why. Okay, so what is your differential diagnosis? On top of my list, I will put diagnosis. Okay, other differentials include this and this. At the bottom of my list, I will put this diagnosis. Okay, and it is unlikely because the patient mentioned this. Okay, I will mention why I put them at the bottom of the list. Okay, and that is again, sorry, mute please. Someone mic is open. I will mute all. Okay, so just last point within the history, how to analyze your main complaint. Here you have plenty of time. You can ask everything. Literally, you can ask everything. You have a lot of time. Sometimes it will be more than necessary. Okay, so you can ask everything. So in order to memorize which question to ask, I have made a mnemonic. Some people prefer OCD, AAA, and SSN. Some people prefer Socrates. Okay, I have made my own anyway. Okay, so mine is Socrates. Okay, the S is for, are you able to see the screen?
Yes, doctor.
So the S is for site of the pain, for the SS, site of the rash. Okay, and with site you have to ask about the radiation. Why? Because radiation is another site actually. Okay, so I have got chest pain. Does it go elsewhere? Yes, doctor, in my arm and neck and jaw. Okay, so we cite radiation. Okay, and sometimes it is not radiation, it is other sites. I have got rash here in my chest. Is there rash anywhere else? This is to assess the distribution. Okay, I have got joint pain, doctor, in my right knee. Is there any other joint affection? Maybe he has poly articular arthritis or oligoarticular arthritis. If you do not ask about other sites, you are going to mistakenly think that it is monoarthritis. Okay, so with site radiation makes sense, and then with onset you have to ask about the trigger, because usually the trigger is the cause of onset. Doctor, I have got right knee pain. When did it start? 2 days, doctor. How did it start? Suddenly, doctor. Anything brought it in? Anything brought it on? Okay, any history of trauma? Any history of injury? I have to search for the trigger immediately with the onset. Okay, then with nature, severity. With nature, severity makes sense, because severity is a nature. Severity itself is a nature. If I ask a patient to describe the nature of the headache, he will tell me it is severe anthropine, doctor. Severe anthropine. Anthropine is for the nature. Severity. If I give you a score of 0 to 10, 10 being the most severe pain, how would you score your pain? How would you score your headache? If I give you a score of 0 to 10, 10 being the most severe headache ever, how would you score your headache? 6 out of 10, doctor. Okay, don't worry, Mr. John. I am going to give you painkillers to help with the headache. Then I will move to the next step. Okay, here I will ask about the course. Is it getting worse or better? Is it getting worse or better? Then the next step, what makes it worse and what makes it better? Any relieving factors, any aggravating factors. And then the T is for timing, timing during the day or night. We mentioned headache of increased intracranial pressure, early morning. Headache of fossa, early morning. Symptoms of asthma, late night or early morning. Symptoms of myasthenia gravis at the end of the day. So timing is also important. This is a way to analyze your main complaint. So hope this is clear. Is this clear?
Yes, doctor.
Okay. So we will be taking a break of 15 minutes, and then we will join back to do some cases. Okay. So keep the link open. We will join back after 15 minutes.